Okay.
I'll take shrimp.
Shrimp? Yeah, go.
Do you really have shrimp?
So, before we get started, if you haven't already met Sue, comes here every month and meets with Dawn and myself, and sometimes George joins us. She's from Finger Lakes Health Systems Agency, right?
Yes, that's exactly.
FLHSA, and she is our.
I'm your advisor for the CMMI.
So she's helped us through for the last year. So, anybody remember when the last time we had an office meeting?
A long time.
5 years ago.
5 years ago, because I told you that to make sure that you.
I was going to say 5. No, wasn't it more? Because I don't think I had Mary Jane yet.
It was right before EMI. Can you believe it? So we don't have these very often, and that's kind of a boo-boo. We really should have these more often, but they're very challenging to get you all here. So thank you very much, because it is, I know it's very hard. It's hard for the doctors just to meet with me. It's even harder to get everybody all together, but it's really important sometimes to be able to get it done.
We have this projector now.
And now we have a projector, as recommended by Dr. Yu.
Oh,
It's all her fault. So,
Whoa.
here we are.
Are we having a raffle?
Before you look at that,
What are we having?
it's a raffle, right? So what are we talking about today? We're first going to talk a little bit about the past. We're going to talk about 2014, because it was kind of a challenging year in a lot of ways. But we're also going to talk about what's coming this year. There will be new challenges. Will there be as many? Will they be as hard? Well, we'll see. But first, we do have a lot to celebrate, because 2014 was packed with lots of challenges. So it's definitely time to celebrate.
Oh.
Yes, we are sharing that giant bottle of champagne with all of you, because it means that much. I mean, it has been one incredible year. I know at the very end of the year, all of you were like, you have got to be kidding me. What else do you possibly want me to do, Andrea, right? The doctors had that same feeling. Everybody had that very same feeling. But we did it, and we did a lot. So I want you to stop and really think about what we did. While he comes around and pours it, a nice glass of champagne. So, 2014 accomplishments. All right.
Separate them.
I don't know, the champagne might not be a good idea.
Right. I did have that thought.
Wait till
we do
the
that at the end. No, I want you to be able to drive home.
Congratulations, everybody.
Yep, here we go. That. Screwdriver time.
Just punch it down.
You're too strong, see that?
Can you punch it down with your finger?
I've done that before.
You don't have a bottle over in this office, right?
We don't drink it.
Do you want a screwdriver? I can go get a
I
screwdriver.
figure we have some.
On a keychain.
Somebody must have it on a keychain or something.
On a keychain?
I don't.
Go, Erin, go.
This is like, let's make a deal. Who's got what in their purse?
Lisa, you know where the tool
Yes. You
thing
want
is.
that?
Can you just bring that up? Yeah. And I'll take mine down.
Make your employees drink.
Yeah, because the pressure is going to
I have to tell you.
Here we go.
Bottom.
All right, let's try again. So, at the beginning of the year, what were we doing? Well, Dawn was here, right? She had already been here for 5 months. So, what did we do in 2014? Well, we further integrated her, because we were learning as we were going how to deal with the care manager and how to have her help each of the practices in a different way. Also, behind the scenes, I was working with STI trying to develop this query system so I could pull out the right data, because the program itself didn't offer the right reporting capabilities that we needed for Finger Lakes and the CMMI project. Let's back up. I told you what FLHSA is, right? That's Finger Lakes Health Systems Agency. They're the local people that help us in the Great Dawn. They're helping to guide us through the Center for Medicare and Medicaid Innovation project, where we're doing just what the government wants us to do. Okay? So we developed this query system. It was very challenging at the very beginning, but now it's kind of a regular thing. And every quarter, I mean, to pull this information and report it back, and then you get compared to all the other people that are in this same project. And from the very beginning, we focused on uncontrolled diabetics. So that's a patient population that we wanted to do better. So we were gathering data to try to figure out how to do better. We implemented huddles. We've never had huddles before, but they do kind of make sense. They're quick and easy, and they go through the day and kind of identify certain issues before they happen. And I think they're kind of regular, and most everybody likes them who participates in huddles. And we improved our transition of care plan. That's it. So for hospital and ER discharge. All right.
I have one in my purse.
Right.
A year ago at this time, we were one of the first groups to present at one of the Finger Lakes meetings about a practice improvement project that we were working on. And so with our uncontrolled diabetics, we wanted to show that what we had done really did make a difference. So we took data on 48 patients and showed everybody what we were able to do. And this was incredible. What this graph shows, and I think a lot of you have seen this graph, is that any negative number means that we brought somebody's HbA1c down through care management efforts. This presentation, this graph, has now gone viral, shall we say? Because this was shown to all of the people at Finger Lakes. Finger Lakes now took it and has shown it to insurance companies, other entities, and said, this is why care managers work. This is how it can work. This is very important, and this is actually going to help us with payment reform to prove that we need a little extra help to be able to have care managers in the facility. And then back to that query system. So every quarter we report, right? So what happens with those reports? They get compared to everybody else. So each one of these numbers is a different practice or group. We're everybody here is lumped together. We're number 22. At the top it talks about, this is again about our diabetics, and this is controlling their LDL. So all about this project was, can we do better than where we started? And with every single quarter, we've done better. We're making a difference. And it's really hard to do because every time that we report, it's over a very long time period. So you can only make a little difference every quarter, but we're certainly trending that way. Did everybody else? Some do. Some did better than we did. But some are kind of all scattered and all over the place. And then you go to HbA1c, and similarly, every single time, we're doing better. So that proves that the changes that we've made have made a difference. And that's pretty exciting. What else happened this year? We welcomed Dr. Yu. And we also welcomed Beth and Alyssa. And we also welcomed over 500 new patients in the last 7 months. So that's pretty incredible. We'd like about 1,000 more, but we're getting there. And that's no small feat. It's wrong direction. So I think they all deserve a round of applause. And I think you'll all agree that all of them have been a great addition to the practice. It's really hard to find just the right people, but I think we found them. So that's pretty cool. What else did we do?
Well, you're included.
We did a lot of equipment upgrades. I actually went back through the places because I couldn't quite remember where the demarcation was. But in 2014, we implemented electronic faxes. We got a new server. We got a new wireless system. We got dual monitors for the secretaries. We upgraded our printers and copiers. We got all new nurse computers, and sometimes they work and sometimes they don't. We got a lot of doctor tablets, except for Dr. Manella, who at least upgraded her operating system. And then we got a phone system upgrade. So we did a lot of technology upgrades because that's so important. I mean, the infrastructure, you got to maintain it for things to continue to happen. So all told, it was over $45,000. That's a lot. Not too many years do we do that. So we won't be doing that in 2015. What else did we do? Patient portal. Was that one of the hardest things ever? It continues to be one of the hardest things ever. What? No? It's easy for you guys. But that was really one of those practice improvement focuses to really get everybody signed up. And we did it in such a way, it was a really cyclic kind of challenge, right? We went out, we started getting people, we reported, we went, oh crap, we don't have enough people here, we don't have enough people sending us messages, change how we're doing it, try again, measure again, change again. So, and that's exactly what we'll be doing and a whole lot more of. We updated HIPAA, started having everybody re-sign for HIPAA. Prevnar came in September. The ACIP guidelines changed. And did we react? Oh my God, did we react? From October 1st until the end of the year, we gave 464 injections. That is phenomenal.
400 of them.
Yeah.
Wow. But I mean, that just goes to show you how quickly we can adjust and make a change. And finally, meaningful use. Or some people say meaningless use, but wow. We implemented electronic lab order. Now we scan EKGs and say that we're tracking them as an image. We are reporting all of those vaccinations that we're giving to ISIS and ISIS. We had to do recalls. We twisted our arms in some ways and became innovative with some recalls, and some of you don't even know what recalls we put out there, but we did a bunch. Direct messaging. Again, some of you don't even know what this is. This is giving doctors and even staff the ability to essentially send a secure email to a physician outside our office, and it stays secure. So we have seen direct messages show up on a to-do list, and that's pretty miraculous. And if you really think about it, it can be really powerful as well. It can actually someday replace the fax, because it's a different conduit but still secure. Referrals. Now the doctors can actually choose referral people. It shows up within the note, it shows up on your clinical summary, and it offers a different, and some people do and some people don't. And some are doing better than others, but it's another opportunity. And we also started those heart failure assessments, because that was kind of it's been craziness at the end of the year. That was a lot of work. That was amazing.
Cheers, Andrea.
I want to drink up. You deserve it.
Oh, that's fine? Afterwards.
Right?
Oh, we're only about halfway down. Okay, there we go. All right, on to 2015. So what are we going to do? Sorry, we're still doing this. And now not just with me, it's with the entire year. So some of you probably have noticed that I've already posted on the reports, new graphs, and I think that now that we've done it 3 months, it should be a little bit easier now. And in some ways, it'll be easier doing it for the entire year as compared to just 3 months, but in other ways, it will be more challenging. It kind of depends on the measure. So we still have to keep measuring and charting so we all understand where we are. And because if we fall behind, there are times when it's very hard to catch up. Last year, Dr. Yoon was doing different measures because she was stage 1 meaningful use. Now she's stage 2, so now her measures are exactly the same as everybody else's, because that created some confusion and sort of a graphic thing. So again, revision of the post. E-prescribing controlled substances. It becomes a requirement by the end of March. You've probably already heard of other practices starting to do it. Actually, way back last year, beginning in March, it was an allowable thing. It's just that your software had to be able to handshake with New York State. As of February 17th, we'll be able to handshake with New York State. Will that take away the need to do the PMP registry? Sorry, no. Will it be as easy to prescribe a controlled substance as normal then? No. Do I know exactly the workflow? Not yet, but there is a slight complexity to it, but at least we'll be able to do it rather than people come in or mail the prescription to pharmacies, things like that. So that'll be a new.
But it'll make printing them, signing
Right.
them. It's gonna make some of the workflow easier.
Right, absolutely. It's become apparent that we absolutely need a website. And I've had 3 offers. I've had Chris Manella, I've had Dago, and I've had Rich Weitzel say, I can do this for you if you would really like me to. So we need to pick and choose and move on. But it's become very apparent that that electronic footprint out there needs to be controlled, and we don't have control over it right now. I worked really hard to control Dr. Yoon's because she was all messed up, still saying that she was at St. John's, and people would actually drive to St. John's thinking that they were going to be seen there. So we tried to fix that. It was kind of a pain, but but if we have our own website that is set up so that Google finds us, Bing finds us, that we're the #1, that will help Dr. I hit the wrong button.
You didn't even have champagne yet.
Right.
How many patients does
We did.
that? Some of them called and they're like,
We left that a long time
confused.
ago.
I'm at St. John's. Am I really going into St. John's?
Sorry about that. And they say ICD-10 is coming back. And they say for real it's coming back this October. I won't believe them for another couple of months. But I do believe that Chartmaker does have a pretty cool crosswalk. I think we kind of know what we're going to be able to do with it. But in another couple of months, once we really know that it's going to happen, we'll start working on this as a project as well to get all of the providers sending charges and get that workflow going. One of the bigger things that's going to happen later on in the year is all those diagnosis codes that are currently in charts need to fit to ICD-10 codes. So that will be a huge job.
That'd be probably part of the prepping of the chart, though, right?
Right. Then we have accountable health partners. You've heard of AHP. So all of our doctors participate with AHP. What is AHP? It's an accountable care network that may eventually become an accountable care organization. Way too many A's and C's and all of that. But again, this is kind of being driven by the government. And it's about healthcare reform and payment reform. So what we're trying to do is get a line right now. Most of the doctors that participate with AHP are strong doctors, but then there are people like us that are community doctors that also align with AHP. So we're supposed to be one big family. right now, there's a project that's going on that you don't even know about. We're in the initial phases of developing a dashboard. What the heck is that? Every night, probably 2 to 3 months from now, there will be a program that goes and looks at our database, pulls out data, and then the next day you'll be able to go on, and any of you will be able to go on and look at information in a much more organized way. So it's for all of you. You'll be using it for pre-visit planning, doctors and nurses for pre-visit planning. We'll be able to address population management. For instance, like we chose uncontrolled diabetics. Maybe we'll say, well, now we want to go after those diabetics who we don't have an eye exam for. It's been one of those things that's kind of a pain in the neck. We think we're better than we are, and we're only 26% or something like that. And that is not because of our fault. It's frequently the eye people aren't sending us the reports. It's not necessarily true that the patients aren't going, but it's a focused project that we can do better. But we can identify those people now through reporting, like we'll get from this. And so again, we'll use that information to improve one way or another. And this is what the dashboard will look like. It'll be very interactive. You'll be able to choose all of our doctors and measures accordingly. And this is a little bit purposely, you can't see the details of these measures, but it has to do with diabetes and mammograms and colonoscopies and all those things that primary care is all about. So you'll be able to drill down and say, I want to know all about the diabetics that we saw in the last month, and be able to create a report that way, which I can't do that very easily right now from China, which has driven me crazy for a long time. AHP is also helping us toward the bigger and better thing, which is becoming a patient-centered medical home. And this is what we'll take a little to explain. Finger Lakes has helped us because everything that Dawn has been doing, everything that we've worked with Sue, will all apply to becoming a patient-centered medical home. AHP is helping us by funding a consultant. So every 2 weeks for the past 6 weeks, I've been on the phone with this consultant laying the groundwork. And now Dawn is also joining me on those calls. The goal is, by September, is to become a certified patient-centered medical home. So, what is it? So at the very top it says, it's a nationwide initiative to improve primary care, replacing episodic care with coordinated care and long-term prevention services. What is it? Federal government is saying we got to improve primary care by improving the quality, reducing costs, and improving the patient experience. Is that helping you? We need to offer greater capacity because more people are going to get health insurance because of Obamacare, and now we need more PCPs, but that's really hard, so can we get our PCPs touching more people? Maybe. So it's what the government likes to call a triple aim approach. We're looking at per capita cost, the experience that the patient is having, both as a huge population and as a single person. I don't think that really helped, did it? Does this help even more? Oh my gosh, this is a confusing mess. Help me figure this out. Well, yeah, geez, it says that we're in the driver's seat, but are we? We're being driven to do certain things. I don't know, but healthcare is too expensive, but we've got to increase quality. How can we do that? Shouldn't they be paying us more for better quality? What is this? This is hard. So let me put it into perspective that maybe you can begin to understand. And let's compare meaningful use to patient-centered medical, because you kind of know meaningful use right now. So Why did the government want us to do meaningful use? They wanted us to prove that we could meaningfully use our EMR. And I would attest all of those numbers that I posted on the wall annually. So we've done that now for 4 years. By testing, what I do is I go onto this website and take all those numbers and put them on the website. Do they trust me? They do, actually. We've never been audited.
Better knock on wood.
I know. But I am so ready if they audit us. Especially this year, because it just feels like they're going to come. But there hasn't been an audit. But what do we get if we do it? There are incentives, and we also prevent being penalized. So there are practices out there that said, screw it, I am not doing that. And now Medicare in particular is penalizing them. And watch out, I bet other insurance companies will get on board and do similar things in the future. So how does that compare to patient-centered medical home? I think what PCMH is, it's a government-defined, ideal primary care practice. Plain and simple. They break the rules, we fulfill the rules. Every 3 years, they change the rules. Does it become easier or harder? It becomes harder every time. If we had started 6 years ago, like a lot of people did, back then, they just filled out the paperwork, didn't necessarily follow the paperwork, said this is what we do, and there they go. They cracked down on that, that doesn't happen anymore. Similar to this, you have to test, but it's like you're audited right at the same time to be able to certify. So you have to provide all the documentation, screenshots, data, all of that, and it's a big process. Why do you do it? Insurance pays a premium to patient-centered medical home practices, because what PCMH focuses on are large groups of people, and hopefully you're touching more people, and it's kind of also the beginning of getting the point. So how does meaningful use, our Finger Lakes people, and PCMH, how does that all handshake? Well, if you think of all the requirements of patient-centered medical home as a big bubble, as I said before, everything that we've done with the Finger Lakes program fits. And most of meaningful use fits. So that means we must be well on our way to getting there, right? And it does mean that. So we've worked very hard to continue to align ourselves for what's going to happen in the future. So, haven't we been patient-centered the whole time? That's why we're here, right? And geez, we even treat them like family, a lot of them, right? And we're even organized in such a way that they don't see a bunch of different providers and a bunch of different nurse practitioners. They mostly see their provider or maybe a nurse practitioner. Recently we did an assessment. So Sue sat down with us, Dr. Plain and Dawn and I, and we went through all these different categories to say how close are we. And so on a scale of 12, we're 1.4. So we are pretty good already. So what do we have to do? We got to do a lot of documentation. So it's not good enough to just do it. We have to write it down and say, this is what we do. And Lisa might do it a little bit differently than Kristen. You know, there might be a little tweak here and there. But in general, we want pretty good consistency across all of our practices. The nurse's favorite thing, the DSS alert that pops up. Sorry, we're going to have more of those. Because there are more things that we're searching for to try to find and control and make sure we're doing at the time of the visit. We're going to be creating this library of evidence-based guidelines. Well, what the heck is an evidence-based guideline? Well, these guys are reading the New England Journal of Medicine. They're reading all the newest, latest, and greatest things. They're going on to update. What's it called?
Up to date.
Up to date. There's a whole bunch of data out there. Well, we want to focus in on some particular ideas and make sure that everybody has the same approach, generally the same approach to dealing with certain diagnoses, certain injections, things like that. Just channel it a little bit. You know, what's interesting about this office is they all practice medicine pretty similarly from the very beginning. So this really is smart. We want to expand population range. We want to go after other things. COPD. Name a diagnosis. Let's see, is there something that we want to do a little bit differently to approach? We need to include the patients. We need to get their opinions about how we're doing. So, yeah, we'll be doing surveys. What's that?
The suggestion box in the beginning?
You know what? The consultant recently said that.
Oh.
Yep, she did. Because that's easy. But we actually need to create a little advisory board to have a discussion and see what they would tell us. Interesting. What's that?
Can we hand the patients on
Yes. Absolutely. It is not a volunteer basis. And then lastly, and my big deal is always quality improvement. Find those things that we can do better. And I think just about everybody who I hired during that initial discussion going through the job description, I always said, and if ever you see something that you think we can do better, we're always willing to listen. We always want everybody's input. And so this is just an extension of that. But we'll be using all of these things to define what project we're going to go after to improve. How do we make this happen? Well, I told you we have a consultant, right? Doesn't she do everything? And not so much. Dr. Manella's going to do everything. Because she is our defined champion for this project. And somehow I always get the project manager position. And then Dawn is definitely in here. She's critical to the whole thing on the patient center. But look, Amy gets a new title.
So maybe we get to keep her and she's like,
We have convinced Amy to stick around for a little while. So Amy will continue to be Dr. Plain's secretary on Mondays and Fridays, but on Tuesday and Wednesday. I get her. No. She becomes our patient-centered medical home implementation assistant and data manager because she knows Excel even better than I do. And she'll get excited, probably more excited than I even do about all these numbers and trying to figure it out. So, and it's a great stepping stone for her to potentially bigger and better job too. So she'll be stationed in the back on that back computer on Tuesdays and Wednesdays. We'll start tomorrow, and she'll probably continue on next week, even though I'm not But it's going to take all of you. You know, these four can certainly point in the right directions, but we're going to need everybody's help to make some changes, identify some workflows. So we'll be probably meeting a little bit more as practice teams and also as job-related teams. So, you know, everybody, we all do rather regularly meet right now. The nurses we have a harder time with, but we're going to have to fix that. But do expect there will be more discussion on these because there's a lot to explain and a lot to understand. So, Carol, how long have you been in healthcare?
over 40 years.
40 years, over 40 years. Oh my gosh. Melinda, how long? How long? Yes, sure. Melinda, how long have you been in help here.
Thank you, ladies.
How long, Melinda? Come on.
30.
30. Oh my God. And then there's Alyssa. How long have you been in that? You. So we all have a different perspective of the evolution of healthcare. But y'all remember these? Those old-fashioned paper charts.
Wait, I remember before that.
Yes, that's true. And so think about the old-fashioned way that we saw patients back then. And this leads us back to what is episodic care. Back then, a patient would call, whatever problem, we come in and deal with the problem. You come back and you say, oh, you need to come back for a physical. Again, it's every episode, but could I walk back into the chart room and say, oh, look, there's 850 diabetics here. I wonder, did we miss anybody's HbA1c in the last month? There was no way to figure that out. I hit the wrong button again. There we go. Now we introduced EMR. And that was really painful for everybody who was here back then. That first year was really, really painful. But I was in the back getting excited because I knew that someday we would have this really cool database that had so much data and it would make all of those clicks worthwhile because we could go find things then. And that's what we're doing now. With all of our reports, now I can run reports and find people in a different way. And that's just what patient-centered medical home wants us to do. What are you saying about that?
Why you took a picture?
When did you take a picture of the wall?
It was actually a few weeks ago. And I wasn't intending it to be used here. But that's kind of the trend. So did I help you at all get to patient-centered medical home? There's a lot of details to it. If I printed out the guidelines, which I just emailed to Amy, it's about this thick. And there's guide element after element and guidelines within the elements. And I can't even begin to show it all to you. But just to give you that feeling of why would it make a difference? And again, to go back to payment reform. Every day, things are changing out there. And today, even Sue emailed me this new announcement that there's a focus now on getting away from fee-based payments. So a patient comes in and we charge a 99213 and an EKG and stool biopsy and whatever. And that's what we've been doing for years and years and years. Eventually, we want to get to, we're going to take care of a life for a certain amount of money and define that life based on how challenging they are. And so today's announcement had to do with Medicare wanting 30% of all payments made in 2016 to be non-episodic. That is, they want to pay us for coordinating care for a patient, for calling VNS, for following up on their blood work, for actually doing some of the things that we already do, but paying us a little bit extra. So it's going to be hard, and there will be stumbles along the way, but we're already starting in on that payment reform model. Okay. Questions? Sue, do you have anything to
Well,
add, thoughts?
what I would want to say is that I'd really like to hire Andrea to come with me and tell everybody else about PCMH, because she really did a great job. But I would say that, PCMH, most of the time, if when you talk about being a medical home, we'll talk about payment reform. But really, it does go beyond that. It's just that that's the thing that drives the change. It goes to the heart of the issue, which is our fee-for-service. Some of the unintended consequences of having a fee-for-service system is that we created all these specializations, which are great for patients, but in turn, it was always the patient's responsibility to try to coordinate all of that care and make sure that they knew their history and understood all their tests and was able to bring that information back to the physician. And as our population ages, the number of specialists that our patients have to see increases, and their capacity to be able to do that at the same time decreases. And so that's the long way of saying it affects their outcomes, and it affects quality of care. And it's not because of any one thing that one physician does. It's because of the complexity that we have in our healthcare system. And so the other piece of patient-centered medical home is it's a best practice for coordinating care and for really looking at the needs of a patient and how much they understand what their care is all about. And that's a lot of what Don does. That's a lot of what the patient experience piece of being a medical home is about, is how often do we give directions to patients and really know whether or not they understand them, whether or not they value them based on their cultural background, religion, things of that nature. We're a more diverse society. So patient reform is critical for primary care to be able to do this work, because it takes more people. It takes your new data coordinator, it takes you're hiring a care manager, so there has to be payment reform away or including other things other than fee-for-service. But really the true goal of it is to help improve patient outcomes in a more complex healthcare system. So that's what I can offer to you. I hope that helps a little bit.
So we're not becoming a strong practice, which is maybe somewhat what you thought we might be talking about today. I was concerned that all of you were out there chit-chatting, saying, "Oh my God, there's going to be something big for us to have a big meeting like this." But
is there like a projected timeline for this reform, so to speak? Because I've heard other doctors talk about how, yeah, if you can just stick with it, then eventually this reform will come where it will be a more patient-centered kind of a model, and where primary care physicians will be reimbursed for all of this work that they do. But I mean, when will that be? I mean,
So,
is this just another experiment that maybe it won't work out?
I couldn't give you exact numbers, but the announcement that came out today actually talked about the incrementally moving towards exactly what you're talking about, Dr. Yoon. So by 2016, Medicare wants to have 30% of reimbursement be bundled, a combination of your ACO, bundled payments, think PCMH, and other coding enhancements. By 2018, I have it here because I know everybody's going to ask me about it. They want 50% to be a bundled payment. But in addition to that, here's the interesting thing: 85% of Medicare fee-for-service payments are going to be linked to quality and value by 2016. And then 90% by 2018. And they asked in this press release that they had, the federal government asked all the states, Medicare, the insurance marketplace, Medicare Advantage, to all commercial and private insurances to all move in the same direction. And they're going to make it incredibly difficult for them not to do that. So we're really looking at quite a transformation by 2018. If all of this continues, and sometimes, there's always the chance that our politics could change that, but that's the plan. That's the, I think the bigger piece. But they definitely have a plan.
And like my sense is, it's like a capitated system. Like you're going to have so many patients, you're going to get $1,000 per head, and so you have a full year to maximize their health care. And so if you can minimize how many costs you generate, you keep the extra, And so I think that's sort of my sense from all of this.
And unfortunately, it could be simpler, because you're going to get enhanced payments already once you become a patient-centered medical home for your Medicaid patients, and I don't know how much that's going to impact you. but you'll get enhanced payments for that. You're going to get, you're going to be using the chronic care management codes as soon as the grant's over, which is going to provide you with money for basically doing care management. And then you're going to have all these other per member per month times, types of bundling. It's the American way that it's got to be complicated. It can't just be, one thing. The last thing I would say about it is I do get the sense that being a patient-centered medical home is going to be very important to participate in any kind of future incentive program and or any kind of federal grant project like the one that you're in right now. So there's multiple implications for being a patient-centered medical home. Financially, I would still go back to the patient quality piece because there is a real purpose behind it beyond the financial piece.
We can stop talking about patient-centered medical home. Were there any other things that popped into your brain as a question or a discussion topic as we went through 2014 and expectations for 2015 that might be a good thing to talk about when we're all here in one spot? Here. Sharon has a question.
I guess my
Oh, God.
question.
I need another drink.
So now it's a suggestion. You should see Dr. McMeekin upstairs because you have. We give him a phone number and we ask him to call. We're not taking them up there. We're not
You don't handhold them
hand-holding
all the
them
way
up there.
upstairs.
But we can't make sure that they're following up on their keratosis that they have on their face or whatever. I mean, is this going to kind of come back because we're not holding their hand to go up to the dermatologist?
Our system needs to be able to track a referral like that and make sure that we end up getting the note back.
I would say the consult
From-
note tracking those.
Right. To prove that, oh wait, if they didn't go, we go tickle the patient. That's kind of what we're doing with our labs right now.
And
As a
referrals
result
and all
of
that.
putting in a lab, now we can see that they didn't go. And I think that was a big surprise about how many people really haven't gone,
Doesn't the referral direct messaging kind of help that a little bit?
It can if we use it in the right way. Yes.
Andrea, that's a good question.
Yeah.
We can't make these people go, so when we do call them and remind them, and we do say you need to follow up and get your labs done, what happens then? And how long do we let this sit on our list for?
You never close the loop,
right?
Yeah, what's the patient responsibility after we've called them twice?
Yeah, I mean, I can help you answer that because I know of practices that are already doing that. So your responsibility really is just to know if a patient has or has not done it and then to send them one contact to do it. That's your technical responsibility. I've done projects and practices where just by virtue of tracking those labs and knowing who has or hasn't done one and reaching out and communicating to them, we did a baseline data. We did a baseline data on how many labs were actually completed prior to starting the project, and it was 66%. And then today, I just met with this practice. We implemented our process for tracking and contacting, either mailing or calling the patient, and it bumped up to 83.78%. So you're never going to be expected, to reach 100%.
You're not expected to go twist their arm and say,
Right.
you have to go upstairs. That's not the expectation.
But just knowing.
Obviously, we document it in the med chart, like medical intervention. Is that where we would document it? Because we can't document it on the actual lab.
Yeah,
That we
you
call
open
Oh,
a-
that it's still open. That
You
you-
open a
yeah.
medical intervention, or what do you open?
where we
So what's the
documented that we
best way to-
contacted these people.
Do I have all the answers?
That's exactly.
That's what we're.
Put it on your
Well, yeah,
to-do
open
list.
it
That's
up.
right. That's what we're developing, those
Okay.
systems to say, yes, this has been contacted.
Okay.
Right, because colonoscopies are probably the worst ones. I
Yeah.
mean, you know, it's.
Right.
I've called people like 3 times over like a month period. They
And
don't
you
call.
discharge them,
Another
right?
one negative.
No.
Sometimes.
We have
Such
to
a
leave
problem.
it there till we speak to them according
Yeah,
to
but
my
The
book.
negative.
Yeah, is it gonna
Never
be
doing
the same system?
But it gets to the point where I feel like I'm harassing people
It's
sometimes.
tough, it's tough.
That is the goal, is to agree on a guideline
Yeah.
across all 5 practices, so that, yes, we have very similar.
So we don't have to call them 5
Processes.
times over and say, why haven't you done this?
Right.
And it's not on our list for
And again, and that's why this is kind of nice, because it does make us stop and formalize it, and then communicate it, and then measure it, and make sure that we're doing it, and then move on.
Because there's going to be an incentive to discharge patients. You know, when you gave us the list of A1Cs, because there's people who are under Dawn's care, and she knows my patients very well, that just don't budge their A1C. You know, they'll get it right one day. It goes from 8 to 11 in 3 months, you know, and we're back to where we started. I mean, those patients are going to bring down my average, you know, and so that's, you know, I don't know. You know, is that a punishment enough?
You have to
No,
hold
well,
the
you
patient
can't-
accountable for
Are you
their
going to discharge them?
actions.
I mean, are we just going to
No,
discharge
you can't
them?
base it on, you have to base it on a patient-doctor relationship.
Sure.
So if
Oh, I
you've
like that.
maintained a relationship, you're not gonna-
That's why there's
if
so
you
much
can't
practice.
maintain a relationship, then you would discharge
Okay.
them. It's all based on the relationship.
Because
That is the
that's-
fear though, right?
that's-
That's the whole
that's-
fear
yeah,
that's
of
the
these
fear.
measures,
That's
right?
right.
That's the
Yes.
fear the
That
doctor is
graph
saying,
doesn't look
why
like
do I
that
want an
anymore.
11.6
and
in
you
the
know,
graph?
and I can,
Fees
and
are
I
gonna
can,
get cut.
You
because
don't
now
wanna get into
Yeah,
that
because
trap.
it's going to be much easier to
Exactly.
track them
That
because
is a lot
we're
of
doing
the
our
fear.
LDLs right now because
That
I
is
have
the fear.
patients who will refuse even though the new guidelines came out and I did their cardiac risk score. I open up to date, I do the calculator and I say your risk of having a heart attack in the next 10 years is 20%. You really need to be.
Good to go.
Stay on my, you know,
Well,
it's-
yeah, I've done
So
today.
there's
I've
every
done
practice
today.
has that.
Cholesterol LDL
Yeah,
170.
every practice has.
But I'm not going to discharge them because you're still maintaining a relationship with me.
it does not
So
do
you
it.
don't want to get into the trap of
He's
using
respectfully
these sort of-
disagreeing with
Right,
Fair enough.
politely decline.
As long
Yes.
as that politely decline. I mean, you can only do so much, right?
Agree to disagree.
Yes.
Yeah.
Wow, we all said the same thing. Right.
You know, but that's going to be where the metrics are going to stop. We're going to plateau at some point, you know.
Oh,
and
sure.
Right. It's
Well,
never going to be 100%. Like you said, it's
everybody
never
will,
going to be 100%.
And, you know, what some of the national studies have shown is that, you know, you would expect that some of the urban health centers would, you know, do very poorly. But in fact, when they do use the patient-centered medical home, this is my second glass of champagne.
Nice.
It's hard
approach,
to
they're
67.
actually able to raise their patient outcomes as well. So there are some, you know, federally qualified health centers that do very well because they have organized evidence-based care and it's coordinated well. And then there are some, you know, all private practices that, you know, have a typical suburban population that don't do any of that and they don't do so well. So it kind of talks about some of the value there is and just being able to see your data, just being able to see what's going on with your patients. How many of you don't know that what percentage of your patients don't get those labs done? And what about those few patients that won't schedule their follow-up at checkout? And now you can track them and see if they've made an appointment. So I think the thing
You
that
can't make them make an appointment.
no, you can't, but you can reach out and you would be surprised at how many more you can get into care by doing that. So it's never going to be 100%.
Right.
And one of the things that I've noticed about your approach in this practice and Andrea's approach in particular is she takes one thing at a time and she knows exactly what needs to happen and then she gets feedback from every part of the practice and she takes a very systematic approach at it and it's been highly successful. If I could take that and clone it, I would love to do that. You're already so well positioned for becoming a medical home because Andrea and everyone here took the approach of we need to build an infrastructure first. It almost didn't help the practices that got recognition back in 2008 because all they thought they had to do was supply some you know, policies and procedures and dot a few i's, and they did that. And so they've had to reinvent the wheel in 2011 and then again in 2014 because they didn't have the discipline to create, real processes that were meaningful for the providers, for the staff, and for the patients. And I see that as a significant difference here, that you did a lot of that work before even starting your PCMH adventure, I'll call it. So I think you're going to do very well, and in the future as well. Because has it felt overwhelming?
Occasionally,
Yeah,
yes.
at times.
All the time?
I know, right?
I should ask
Maybe
you
if we're
that.
not some of the newer people.
Yeah.
So,
What I came into.
Like, that's what you knew, right? You never saw the others.
No, that's
Right,
right, we
right,
came into
right.
that.
That's right,
I was
no
doing
expectation.
this stuff before a lot of the other practices.
Yeah, I think the challenge, I would speak at least from my perspective, is that, each year it just seemed to ramp up, and then just once we thought we were kind of in a nice zone, then something else came on, and like with the staff and the secretaries, all these signatures with all the new, whatever, the clipboard.
Right, all that
It was just
crap.
so I could hear feedback, that's just one more thing.
right.
So I think with each step, there's at least a time period where it is overwhelming, then we get that under grasp. And then
Right.
a new thing comes along, and
So, right, are we constantly on that slope?
right, it seems like it's
Aren't you taking
more and
away
more
anything?
stuff.
Take away something so we can
Right.
add it back.
I totally understand that.
I think that's the challenge.
Yeah.
Yeah, and
even
it's been
moving
overwhelming
forward.
for the patients. They're getting bombarded at the window with paperwork, then they're coming back into the room and getting paperwork, and then you guys are giving them lab slips and paperwork.
And all the patients like, I thought you were supposed to be paper.
The last couple days, I've had more and more patients compliment us on the lab slips versus the
Oh.
old ones. They really like the computer-generated lab slip because
Yeah.
it's pretty straightforward what you're testing. So
And then
that's
they get
been
to me
good.
and they're totally confused. What was this
Oh,
paper
really?
for? What am I doing?
It's a white piece of paper. It's always
Yeah, it was a white piece of paper. I guess it just depends on the practice, what kind of people you
Well, then Sue, you would think our paper volume on faxes would be shrinking. And Diego luckily sorts through it all.
It's a ream every
And Monday, I came in and my stack was this just
Oh,
for
yeah,
me.
you had it like that.
Well, in some of the things that you're doing, they haven't really embraced or started to do yet, like in hospitals and in other facilities, and you know what the reports are like. They have to meet every federal guideline. They don't care how they meet it, if it takes 20 pages. But I do think that will change. I think it had to be rolled out incrementally, because if it wasn't, it would have been so overwhelming, nothing would have ever been implemented, and so that was the intent. There are still many in the healthcare field that have to be brought online, specialists. That's the next big focus, is specialty care. Hospitals are already changing how they do business because they're not incentivized. They're actually going to be punished, I guess I could say, for having too many admissions and readmissions. So we just happen to be in the middle of all the change, and primary care is, yeah. I do think someday, Dr. Plame, your EMR vendors will also get on board and start creating the EMR for the practice side rather than the billing side, and hopefully that'll be the future.
Yeah. Are we done?